Allow me to move to the next speaker, Dr. Rana Tarek, lecturer of Interventional Radiology at our department. She will talk about vulvo-perineal varices sclerotherapy in pelvic congestion syndrome patients.
Good morning, everyone. It's my pleasure to be here with you today. I'll be talking about the vulvo-perineal varices sclerotherapy in pelvic congestion syndrome patients. So the outlines of my talk will include a brief introduction. I will be talking about the prevalence and pathophysiology of the vulvar varices, how to diagnose, how to treat. We'll show you some cases, and finally we will conclude our lecture. So starting with a brief introduction, pelvic congestion syndrome or pelvic venous disorder is a common worldwide underdiagnosed disease that's commonly associated with the presence of vulvar, perineal, and less commonly inguinal and buttocks varicose veins, which can be alone or associated with lower limb varicosities. So regarding the general prevalence of the vulvo-perineal varices, actually, it's still unknown. However, in a recent series of over 4,000 female vein clinic patients, the incidence of the vulvar varices was about 4 to 5%. And this incidence increased up to 40% in the cases with pelvic congestion syndrome. For the pathophysiology, pelvic venous disorders is better to be classified according to the symptoms, varices, and pathophysiology through the SVP classification, where the symptoms and varices are classified according to the site of the pathology, whether it's renal, pelvic, or extrapelvic, and the pathophysiology is classified according to the affected veins. The etiology and the hemodynamics are classified according whether it's due to obstruction or reflux. And we have 4 zones to consider in this classification: renal, gonadal and internal iliac veins, the pelvic origin, and extrapelvic with lower extremity deep and superficial veins. The studies have described 6 parietal escape points through which the pelvic venous reflux can cause vaginal and external genitalia with or without gluteal and inguinal varicosities transmitted to the lower limbs, causing the varicose veins. They should be suspected when finding extraaxial lower limb varicosities, especially if no saphenofemoral junction reflux is noted. And if it is encountered, we should treat first the pelvic varices, and then we go for treatment of the residual vulvar varices. These pelvic leak points can spread either in ipsilateral or contralateral sides due to the fact of lack of valves in all pelvic veins except for the ovarian veins. So how to diagnose? First, the symptoms and signs can include dyspareunia, vulvar and perineal pain, visible vulvar varices, and it can be associated with extraaxial lower limb varicosities. And for the imaging, we can, through the assessment of the pelvic congestion syndrome and the ovarian veins, through the transvaginal ultrasound, we can see here in this video bilateral dilated veins along the vagina. These are vaginal varices. And this is a superficial ultrasound over the vulva, and we can see the veins refluxing on straining, which is confirmed by the Doppler waveform. And for the treatment, as I've mentioned before, you need to exclude the source of the reflux. If there is a gonadal and iliac venous reflux, it has to be treated first. So we start with ovarian veins embolization. This is pre and post. And of course, we should not forget to embolize the right side. Very important to do it for the embolization bilaterally. And eventually, if also the patient has any source of iliac reflux, like in this case, it should be also embolized. And after finishing embolization of the pelvic veins, whether gonadal and iliac, we should assess the patient after 2 to 4 weeks And if there is still residual varices with reflux, treatment of the vulvar varices should be attempted. And the treatment options can include surgical ligation, invasive, and sclerotherapy, minimally invasive, which can be ultrasound guided only, or combined ultrasound with fluoroscopy guidance. And I will focus in my talk on the combined ultrasound and fluoroscopic guided vulvar sclerotherapy. So for the technique, we have published our experience with vulvo-perineal varices sclerotherapy using combined ultrasound and fluoroscopy guidance. It was an experience in 70 patients. It was me and Dr. Karim Abdel Tawab. But now we have more than 400 cases done successfully. We had 100% technical success and almost 100% clinical success, with 20% of patients needed a second session for vulvar sclerotherapy during the follow-up. So why did we choose to do fluoroscopy along with the ultrasound guidance of the vulvar varices sclerotherapy? Actually, several preliminary punctures have revealed an isolated venous blowout not communicating with the pelvic veins, like in this case. So injection of the sclerotherapy was aborted and another puncture was done. And also we can see here direct communication between the vulvar varices and the external iliac vein through non-diseased veins. They look normal, not actual varices. So injection of sclerotherapy may cause, in this case, external iliac vein thrombosis. So injection was aborted and another puncture was attempted. So for the patient's anesthesia, I choose the lithotomy position, anterior position, and the patient should have ultrasound-guided budendal block using the lidocaine not exceeding 300 milligram. And if the patients need perineal, gluteal, or inguinal punctures, not the vulvar punctures, subcutaneous lidocaine will be enough with no need for budendal block. I use 18-gauge cannula and the 1% polyducanol with using the Tessari method mixture of 1 cc of the polyducanol and 4 cc of the room air to form the foam. Now I will show you a video for the full technique that we currently perform in our IR unit. This is a case of residual vulvar varices after treating the refluxing iliac veins. We can see here the vulvar varices. And when I ask the patient to strain, I can see it refluxing on Valsalva. And this is the assessment during using superficial ultrasound. So I go for a budendal nerve block. I put the transducer in medial to the ischial tuberosity and lateral to the vulva, like in this position, in anterior lithotomy position. And I start infiltrating the lidocaine all around the budendal nerve bundle. And then under ultrasound guidance, I target the dilated varices. As we can see here, the needle inserted in the vulvar varices. After which I should make sure that I'm totally in with free flow of the venous blood. And then I start doing the angiogram by injecting the contrast. And I can see here vulvo-perineal varices bilaterally and connected to the iliac and pelvic veins bilaterally. So I start forming the foam material, polyducanol, 4:1. Then again, I inject the contrast so that I can delineate the anatomy again, and followed by injection of the foam sclerotherapy under screen. And I can see here the contrast is being displaced by the foam material. The foam material is not radio opaque, and so I need to inject the contrast first so I can see it. And this is the superficial ultrasound after injection. I can see the foam particles moving through the varices. And this is post-sclerotherapy angiogram, and I can see that it is occluded with no connection to the pelvic veins, and eventually I do compression for 5 minutes. Patients are advised to wear tight underwear for 1 week and apply hot fomentations if there is some pain for at least 3 days. And then the patients are discharged directly after the procedure with no specific medication post-procedure except for any analgesic medications if needed. And I do the follow-up after 1 week, 2 weeks, 6 months, and 12 months. And if I see that there are still some residual, I perform another session of valvular sclerotherapy. And for our experience, we have done so far more than 500 cases, successful cases. I joined these efforts in 2019. Now I will show you some cases. This is a case of vulvo-perineal varices as seen by the perineal ultrasound. And after ultrasound guidance and after application of the budendal block, I can see here the angiogram showing its connection to the iliac veins. Sorry. I can see it connecting to the iliac veins and the pelvic veins. Then I inject contrast followed by foam, and this is where the foam displaces the contrast. And this is post-sclerotherapy. Another case we can see here on this angiogram, valvular varices connected to the pelvic veins bilaterally. This time I've injected the foam directly without pre-contrast opacification, and I can see here the negative contrast effect of the foam particles flowing through the valvular varices into the iliac veins. And this is the control angiogram post-sclerotherapy. This is post-sclerotherapy ultrasound where I can see the foam particles flowing in the varices. Final case, this is also bilateral residual valvular varices seen refluxing on Valsalva. This is pre-embolization, and this is post-embolization using sclerotherapy. And this is also the ultrasound post-sclerotherapy, and I can also see the foam particles. So to conclude my lecture, pelvic condition syndrome is a common yet undiagnosed disease affecting many women worldwide, and it's commonly associated with vulvar and perineal varices through different leak points that can be unilateral or bilateral. Vulvo-perineal varices sclerotherapy is an effective, minimally invasive treatment that should be attempted after the treatment of the pelvic reflux. Thank you.
Thank you, Dr. Rana, for this excellent